Thanks again. So, morning I had described in detail about how we are looking at intensifying neoadjuvant therapy. Like Dr. Rohit already mentioned, that we would not end up in a situation where we want to plan adjuvant. We want to intensify the neoadjuvant in such a way that higher PAT-CRs are attained. We are now looking in combinations of chemo-immuno in the neoadjuvant setting, and in fact, we are looking at intensification of chemotherapy even in the squamous. We looked at the data in the morning where we are moving away from CRT, and in a more fitter patients we want to actually give neoadjuvant chemotherapy. So very little to add after what Dr. Rohit had mentioned, because the topic was only alternative options. There are very few alternative options. So it's only probably we would only be considering this if a patient has not received any treatment at all. But again, as it cannot be stressed enough that now we are looking at neoadjuvant therapy for all the patients starting from T2 probably. So this would depend on several factors. If the patient has prior received CRT, nivolumab is the standard of care. If the patient cannot afford nivolumab, then chemotherapy, but tolerability is an issue post-surgery. There is some retrospective data which shows that patients with significant residual nodal disease benefited and there was improvement in survival. Yet another retrospective data, I think Dr. Rohit also showed this paper. So there is a meta-analysis of 10 studies where most of the patients had undergone CRT rather than induction chemotherapy. So here in this meta-analysis, they showed that patients who had significant residual disease, they could receive adjuvant chemo, and the chemo choice of regimen was whatever they had not received in the CRT setting. And if the patient has not received any prior neoadjuvant at all, then for adenocarcinoma, we extrapolate from the stomach, and again we give a 5FU based chemotherapy. For thoracic, we don't have any clear evidence. So if we have, the choice is just between chemotherapy and chemoradiation. Like I mentioned, we extrapolate from gastric adenocarcinoma. For chemoradiation therapy, there is some evidence that for node positive, again we can use CRT. So what about immunotherapy? Is there any role at all? There is this trial which looked at adjuvant durvalumab after neoadjuvant chemoradiotherapy, but then this did not show any benefit. There was some benefit in patients with residual disease. What about, so the most of the other agents are only in experimental stage. Of course, based on Matterhorn data. So whatever, when we are approaching, taking the perioperative approach, whatever the patient has taken in the pre-operative setting, we would follow that into the post-operative setting. Like based on Matterhorn, patient would receive durvalumab. Now there is a phase 2 trial looking at zolbetuximab in Claudin positive patients. There is upcoming data about tislelizumab. This is also being looked into. So like I said, there's nothing much to add. We should try and give neoadjuvant as far as possible, an optimal neoadjuvant. Thank you.